All right. Then we come to the system. This is a patient in the left posterior oblique position. Left side is down and oblique because it's not a true decubitus. So in this position, the gallbladder falls forward and it becomes easier for us to see. Probe is put in that position, and sometimes we make small adjustments because the gallbladder does not fall. I mean, in the way we expect. You may fall forward, but be oriented like that. So you'd have to orient your probe in that direction to be able to pick the longest, or the image that gives you the gallbladder in its widest dimension. That would be the true long axis of that gallbladder. For now, we're not dealing with technique. We are just highlighting sectional anatomy, just like the lecture, Introduction to Cross-Sectional Anatomy. We'll get to the details later. Again, your patient can be seated upright, and in this erect position, you can be able to image your gallbladder, and this is the position where you expect to see the gallbladder. But just like I mentioned, there could be small alterations. You might find the gallbladder is not in this spot, but somewhere here, you'd have to slide your probe to this side or to this side. If it's oriented like that, then your probe should lie along that, okay, orientation. Asaf, about pleural effusion, fluid appears dark on ultrasound. So any fluid above or superior to the level of the diaphragm should be within the thoracic cavity, and that is assumed to be pleural effusion. Fluid below the diaphragm or superior to the level of the inferior to the level of the diaphragm is assumed to be intra-abdominal fluid, and that would be ascites. That fluid could also be other things, could be pus, could be blood, but for now we are just dealing with the anatomical orientation. Asaf, I hope I've answered your question. Again, this is just orientation. This is a patient in semi-erect, and you can be able to see this position helps us to deal with gas. Remember, when your patient is lying supine and they're lying straight, gas moves up and occupies the anterior aspect. So when they sit up like this, gas moves towards the diaphragm and frees this area away from gas. Sometimes this technique works, sometimes it doesn't. So this is an example here. If your gallbladder there and sits long axis, this is the fundus, this is the body, and this is the neck. Somewhere beyond this point is where you have the cystic duct that drains a bile away from the gallbladder. Then this is the transverse image showing us the gallbladder in cross-section, appearing as a fine cyst. This is your IVC, appears ovoid, and the aorta, which usually appears as a circle. This is your aorta there, so your spine. Then we come to the porta hepatis. Porta hepatis is important because this is the gateway of the liver. It is an entry and exit point for the liver. That's why it's significant. So as you can see, structures that are coming into the liver, we have the purple system, that's the portovenous, bringing in blood from the GIT. That is from the bowel coming in, usually from digestion, brings in all of these things you've eaten, the foods, the whatnot, the breakdowns of digestion, the chemical digestion are brought here for the liver to continue with processing. Then we have blood here from the aorta, the red system, that is blood from the hepatic artery. Then here we have I want to call this green or lemon green for the ladies. They are very specific with their colors. So this color here is for the biliary system. Bile is made in the liver, it's brought down through the intrahepatics. From the common hepatic here, comes down here, bile is taken here for temporary storage in the gallbladder through the cystic duct, and then Down here, when the time comes, if you've taken fats via the cytokinase mechanism, this will be pushed down into the sphincter of Oddi that is located at the duodenal cup here. So this here is the common bile duct. So this one is exit, these two are entry points. So this image, we highlight the course of the common bile duct, where you see these arrows here, and it continues and dives into the posterior aspect of the pancreatic head, where it joins the pancreatic duct, and the two of them empty into the duodenum via the sphincter of Oddi. The structure posteriorly here is the main portal vein. Again, in this image, this structure that passes above is the common bile duct, the one below is the main portal vein, and the one sandwiched in between the two is the hepatic artery. Sometimes this is a sign of bile duct dilatation or obstruction, and sometimes it can be an anatomical orientation. Now, within the porta hepatis, the structure that lies posteriorly, the large structure, this one that lies posteriorly, is usually the main portal vein. Then the structure, if we took an axial cut through here, that lies anterolaterally is the common bile duct, and the structure that lies anteromedial to the main portal vein is usually the hepatic duct. The bile duct and the artery are supposed to be of the same size. If they are asymmetrical, or one of them is bigger than the other, or one is smaller, there is a problem in one of the systems. Later on, we are going to look at measurement so that we can be able to tell which one is problematic or pathological. This is your hepatic artery sandwiched, and then here you have the main portal vein, and this is the course of the bile duct all the way into the pancreatic head, and it dives posteriorly. The stomach and duodenum contain gas, and gas, as you know your physics, is problematic in the imaging of ultrasound because it gives us the dirty shadows. So the one way to overcome that is either change patient position or ask the patient to take water, not soda. Soda will add to the problem because it contains pressurized gas. So when the patients take it, part of that gas is released and becomes free gas and adds on to the problem. So we'd rather take, even if they just took this water from the dispenser, those hospital dispensers, it's okay. It's enough either to displace small pockets of air so that now we can be able to see what lies behind the stomach. But using ultrasound to assess the stomach itself is problematic because of that reason. And that is why we end up doing these other studies like, barium, meals, endoscopy, CT, etc. So this is an example of our gas pockets. As you can see there, multiple of them giving us shadowing. So you never know, or you never see what is behind there. Same thing here. Yes, these pockets of air are not that big to cause these shadows, but you can see that there is haziness here, and you can never assess what is behind there. So even if there was a mass here, a gastric mass or duodenal mass, you will almost always miss it. Here we have a stomach filled with fluid. Yes, there are small air pockets, but you can see at least what lies, within there. Then this is food within our stomach. Then this is a stomach, and you can see gas has taken the highest point, which is here, that we can fairly assess this part of the stomach. So if there was a mass there, we can be able to see it. The other question I'm asked frequently is, can ultrasound be used to assess duodenal ulcers? The answer is no, you cannot. What you can assess are complications, things like if there was a perforation, in which case you're looking for two things. You're looking for either a pneumoperitoneum, which is free collection of gas within the peritoneum, or you're looking for a free fluid collection within